Good morning. First, thank you, Dr. Joa Wang and Robert Wang for inviting me. My name is Dan Lee. I'm from Kaiser Permanente in Northern California. And I'm very honored to introduce the second speaker, Dr. Monika Laszkowska, who is a clinical gastroenterologist and an investigator at Memorial Sloan Kettering Cancer Center in New York. And she'll be talking about a clinically very interesting and challenging topic, which is hereditary diffuse gastric cancer, management, and role of endoscopy. Welcome.
All righty. Excellent. Thank you so much. And thank you again to Juha and to Rob for organizing such a wonderful conference. And I'm very excited to be here. We've been speaking a lot about H. pylori and precancerous lesions and surveillance. And we're going to switch topics a little bit and talk about hereditary diffuse gastric cancer. And specifically, I'd like to address management of these challenging patients, as well as the role that endoscopy can play in this approach. And so these are my disclosures, which is mostly grant funding from the NIH and institutional funding. And so to dive right in, really, we know that family history is a very important risk factor for the development of gastric cancer. The relative risk of developing gastric cancer in those with a first-degree relative is about 2.2. And we also know that these patients are at an increased risk of developing lesions such as intestinal metaplasia. About 10% of gastric cancer cases do show familial aggregation, and we have a hereditary cause identified in about 1 to 3% of these cases. Now, there are various presentations in terms of how hereditary gastric cancer may manifest. There are specifically inherited syndromes in which gastric cancer is the primary malignant presentation, and one of these is, in fact, hereditary diffuse gastric cancer, which we'll be focusing on today. But I do want to just mention that there are several other syndromes, including GAPS, as well as the more recently characterized familial intestinal gastric cancer, which are also increase the risk in these patients, as well as several other inherited syndromes in which gastric cancer is just one of the many cancers that the patients are at risk for. But for today, we'll focus on hereditary diffuse gastric cancer specifically. And so this is an autosomal dominant inherited syndrome. Up to 40% of these cases are caused by an inactivating germline mutation in the E-cadherin encoding gene CDH1. There are other genes that can also contribute to the syndrome, namely CTNNA1 is one that we've identified, and there are probably others as well. And the notable thing is that the lifetime risk of diffuse gastric cancer in these patients is extremely high. Early studies showed estimates of about 56 to 70% of cumulative lifetime risk. Later studies suggest that might be a bit lower at 25 to 42%. But I think we'd all agree that's a pretty high risk of developing gastric cancer. And the other thing is that these patients are also at increased risk of lobular breast cancer, and that's a very important thing to note in their management, which is about a 42 to 55% lifetime risk. And so the interesting thing is that these patients with these pathogenic CDH1 variants develop these quiescent subepithelial foci of signet ring cells early in life. And 89 to 96% of these patients will have these foci by the age of 20 to 30. And this might range from less than 5 cells to about 100 cells. So these foci can be very, very small and notoriously challenging to detect on endoscopy. And so that certainly poses a challenge to us as endoscopists in evaluating these patients. Usually this is because these subepithelial foci are actually obscured by a preserved surface epithelium. And so that makes it challenging both to visual inspection and on biopsy. And these foci have a very unpredictable potential to metastasize. So we don't really know when these quiescent foci will actually progress to more invasive disease. And obviously, since late-stage disease portends a poor prognosis, this is very challenging. And so given these limitations, right now the current guidelines advise that individuals with these pathogenic CDH1 variants undergo risk-reducing total gastrectomy early in adulthood, so by the age of 20 to 30. And so obviously this is a big decision. These decisions are very complex and very individualized. And for many reasons, individuals might delay a gastrectomy or opt against the procedure. And in those cases, annual endoscopic surveillance exams are recommended. Now, who should we be thinking about in terms of testing for these variants? There are both familial and individual criteria in terms of diagnosis. So On the familial side, if there are more than 2 cases of gastric cancer in a family, with at least one being diffuse gastric cancer, you should consider those patients. In addition, at least one individual of any age with diffuse gastric cancer and one individual with lobular breast cancer under the age of 70 should be considered, or more than 2 cases of lobular breast cancer under age 50. There's also individual criteria, so if only one person in the family presents with diffuse gastric cancer at the age of under 50, that person should be considered, as well as diffuse gastric cancer at any age with some other high-risk features, including lobular breast cancer concurrently in the same patient, or also things like Maori ethnicity or having a cleft lip or palate. Those are also identifying features. One important thing is that there's really 3 subgroups within this population that meets testing criteria, and the management does differ between them, so I think it's important to make sure that they're correctly categorized. The first is this hereditary diffuse gastric cancer group, which is the one we've been focusing on. So these have a pathogenic either CDH1 or ctNNA1 variant, and an individual with diffuse gastric cancer, or a family that has known diffuse gastric cancer cases in a 1st or 2nd degree relative. And these are the typical individuals where we would recommend prophylactic gastrectomy and only offer annual EGD or gastrectomy if that endoscopy is positive. Now, for hereditary lobular breast cancer, these individuals also have a pathogenic CDH1 variant, but those individuals have a history of lobular breast cancer or a family history of lobular breast cancer in their relatives, but no cases of diffuse gastric cancer. And so this just highlights that not all families with pathogenic mutations are going to be at equal risk of diffuse gastric cancer. So here, we would still say to consider prophylactic total gastrectomy. The recommendation is just not as firm in those patients. Or the alternative would be to continue annual endoscopy and do gastrectomy only if you detect signet ring cells. And then lastly, there's these HDGC-like families. So these families have negative genetic testing, so they don't have a CDH1 mutation or ctNNA1 mutation, but they did fill the genetic testing criteria. So they have at least one confirmed case of diffuse gastric cancer. And so this population becomes a little bit more tricky. Usually we do recommend endoscopy in these patients rather than prophylactic gastrectomy with close monitoring and only gastrectomy if signet ring cells are detected. So going back to the role of endoscopy in these patients, basically for the guidelines for how to approach endoscopic evaluations has really continued to evolve over time as we've learned more about these patients. And a notable advance was really the introduction of the Cambridge protocol as part of the guidelines for managing these patients. And the initial protocol had recommended targeted biopsies and then at least 30 random biopsies with 5 bites from 6 different areas within the stomach. In practice, the detection of signet ring cells on endoscopy, even utilizing this protocol, has been extremely variable, even in expert centers. And detection rates have really ranged from anywhere from 14 to 61%, with many of them being in the 14 to 17% range. So as I mentioned, our endoscopies are not really all that reliable at detecting these foci, given that we know that up to 95% of these patients have them in their stomach. And there's also been computational models that suggest that to get 90% detection, you would actually have to take over 1,700 biopsies in an individual, which I think everyone would agree is impractical and not really realistic. But that just gives us a sense of expectations and a sense of how well can we actually detect these lesions. So this is just some data from the initial study that presented outcomes utilizing the Cambridge protocol. So they followed 51 patients with CDH1 mutations, and they were able to detect signet ring cells on 61% of these, either on initial or follow-up endoscopy. So that's pretty much the highest detection rate that we've seen in any of the studies that have been done. And as you can see, the other notable thing is that the highest rate of detection was actually on the index endoscopy, and then the detection rates trailed off a bit, though they were still detected even up to the 6th endoscopy. And this is the most updated guidelines in terms of approaching endoscopy in these patients. So the updated guidelines were released in 2020. They recommend this modified version of the Cambridge protocol, suggesting that really surveillance should be done at expert centers by gastroenterologists who are familiar with hereditary diffuse gastric cancer. And the endoscopic exam should include both targeted as well as random biopsies, with the random biopsies really focusing on the proximal stomach. So they recommend 5 bites in the antrum and transition zone, 10 in the body, and then 5 in the fundus and 3 to 5 in the cardia. Other protocols have continued to be developed to try to really optimize this. So this study described the Bethesda protocol, which actually increased the number of random biopsies to 88 biopsies, taking 4 random biopsies in 22 different zones in the stomach. And so in their approach, they found that they were able to increase detection from 15% with the Cambridge protocol to 37% utilizing this Bethesda protocol with more extended biopsies. And another notable conclusion of that study was that a majority of the signet ring cell foci were found in the proximal stomach, again demonstrated by that heat map, especially in the fundus. Recently at DDW this past spring, our group from Memorial Sloan Kettering was able to summarize our experience with endoscopy in this population. And so we presented data on all individuals with pathogenic or likely pathogenic germline mutations in CDH1 that had at least one endoscopy at our institution. And we had patients that we had followed going back all the way to 2006. So this was a unique opportunity for us to assess a spectrum of biopsy practices, even well before the Cambridge protocol became the accepted guideline method. And so we were able to follow these 98 patients who received a total of 178 procedures. A majority had one endoscopy. There were 32 patients that were able to have 2 or more endoscopies at our center. Our detection rate overall was 20%. Again, this is accounting for a variety of different biopsy practices. And a majority were, again, detected on the initial EGD. 58 of these patients underwent gastrectomy, with signet ring cells being detected in 86% of these patients. And while 2 passed from metastatic breast cancer and other causes, none actually developed advanced gastric cancer. One major area that we were interested in was actually looking at whether targeted biopsies would yield greater detection. And looking at the various different lesions, the main thing we found was that pale areas were significantly associated with detection of signet ring cells. So this has been described before, and we certainly saw that in our experience. Other histologic findings like gastritis or intestinal metaplasia were not associated with increased detection of signet ring cells in our cohort. This is just a photo of the pale areas that we were able to see in our cohort. As you can see, they're certainly enhanced utilizing NBI for visualization, and if you see these areas, they really should be targeted for biopsies. Another important question we wanted to ask was whether increasing the number of biopsies would yield a higher detection rate of these signet ring cells, since that seemed to be a theme that had been brought up in other studies. And so here we showed that as the number of biopsies increased, we did in fact see an increased proportion of EGDs that detected signet ring cells, with the highest detection rates being among those who had more than 40 biopsies done. I will note these are small numbers, though, so further study is certainly needed to validate that. And then another interesting question we thought was comparing whether individuals who had a gastrectomy, how many foci they had on that gastrectomy specimen, and then comparing that to whether we were able to detect signet ring cells on the pre-surgical EGD. And here you can see that as the number of foci on the gastrectomy specimen increased, we had a higher chance of detecting those signet ring cells on the pre-op EGD. And while this intuitively makes sense, it also kind of goes hand in hand in terms of the question of how well do we need to be able to detect these foci, or is it more that our endoscopy is just becoming more sensitive once there's more foci developing in the stomach? Again, similarly to prior studies, we saw that there were more foci of signet ring cells in the proximal stomach. So most were detected in the body and transition zone at around 60%, but also the cardia and fundus were a prominent site of signet ring cells. On the contrary, the antrum and prepylorus was only a 10 to 16% rate of having signet ring cells. And so this suggests that the current guideline modifications in terms of prioritizing the proximal stomach would indeed be supported by this. And then lastly, we also looked at our surveillance data, so looking at patients who had at least 2 endoscopies as a point of follow-up for these patients. So we had 32 patients in that cohort, of whom 7 had signet ring cells detected on endoscopy. Among those that did not, we still have 17 patients undergoing continued surveillance. And among those, none have developed gastric cancer, advanced gastric cancer thus far. Again, 2 patients did pass for metastatic breast cancer, but no advanced gastric cancer. So on that note, I think the optimal timing of gastrectomy still remains a very important question. We show that perhaps short-term surveillance of these patients might give us some leeway in terms of timing, but obviously this is still the current recommendation, is to pursue gastrectomy. And that has many benefits. It eliminates the risk of gastric cancer in these patients, as well as the anxiety that goes along with that. But there are certainly risks, including surgical complications and sequelae following the surgery, like weight loss, malabsorption, and osteoporosis. And so these decisions, like I mentioned before, are very complex, very individualized, and a collaborative decision-making process has to be made. And that involves the patients, their families, as well as a multidisciplinary team to really make the right decision for each patient. Along with Chin-Her, we were actually able to use decision analysis modeling to try to answer some of these questions a bit more on a conceptual level. And so we developed a Markov simulation model to look at how varying the age of prophylactic gastrectomy might impact outcomes in these patients. And so we looked at quality-adjusted life years, cancer mortality, as well as life expectancy. And we also looked at how incorporating endoscopic surveillance might impact clinical management. And so we looked at 3 different categories of strategies: the natural history strategy, the prophylactic gastrectomy strategy, and there we varied the age from 20 all the way to 79 as a conceptual exercise. And then we also looked at incorporating endoscopic surveillance, either until the optimal age of gastrectomy or as a sole strategy. And so this is the main outcome. You can see on the y-axis on the left are quality-adjusted life years, and on the y-axis on the right is gastric cancer mortality. And so based on this in men, we saw that the highest QALYs, which was our primary outcome, was at age 39 in men. So that's actually a bit later than the current guidelines might suggest. And then in women, it was at age 30, so that's on the tail end of the current recommendations. And this chart just details a little bit more about the outcomes we saw in these various strategies. And so, like I mentioned, gastrectomy was the optimal strategy for both men and women at age 39 for men and 30 for women. But it's notable that adding surveillance prior to gastrectomy actually did lower mortality somewhat, though it was accompanied by a lower QALY. And so that is a possible alternative strategy, again, depending on the individual patient. That being said, I think it's critical to say that validation with clinical studies is obviously needed, and real-world data is going to be critical to inform the care of these patients. So certainly that's something that's very important. And so in summary, currently gastrectomy remains the guideline recommendation for this population, but with continued refinement of these protocols, this may help strengthen surveillance as a potential alternative management option in some of these patients, particularly in the short term at least. Incorporating targeted biopsies of these gastric pale mucosal areas and random biopsies focusing on the proximal stomach might increase the yield of our endoscopies and being able to detect these signet ring cells. And also increasing the number of biopsies may be key to improving detection, though again, there's a balance between feasibility and practicality, as well as how many biopsies we might need to clinically make an impact. And then lastly, we really need more future studies to continue to both refine these endoscopic protocols, but also just find better ways to help these patients reduce their risk of developing gastric cancer and minimize the sequelae that they would suffer through those options. Just as a last note, I know we focused a lot on hereditary diffuse gastric cancer in this talk. I just wanted to mention for these other syndromes, for many of them, there are no firm guidelines, but many societies do have some suggested guidelines based on the evidence that we do have. So it's certainly something to think about when you come across any patient with these syndromes to make sure to think about gastric cancer surveillance in that context. Thank you so much.